Hi, Ken Enrico, and I'd like to welcome you to your Welcome to Medicare Visit Back to the Basic presentation. I'm going to let Pat give us a few words to get us started.
Okay, we're waiting for the slide to come up. There we go. Good morning. This is Pat, and thank you for taking your time today. And we know this is something we've been working on for almost now 2.5, 3 years, and we're very excited about the progress people have made. You really have done a super job, and we know we have a lot to build on. You know, we've made progress, but there's still progress to be made. And sometimes during that time of learning, there's some things that we need to freshen up on, and so that's really what it's about here today. And the reason we push so hard is that there really is tremendous value in the Medicare well visits, and it keeps our patients healthy, and gives us a way to assign patients to your primary care practice so they're not going to other practices. It's part of the ACO, getting those lives attributed to the ACO so that you as the primary care provider can manage your patients. They're not going all over. It's a way of also keeping care local, and it's a way that you can identify gaps. When you do the Medicare well visit, are there things that need to be done? Did they get their mammogram? Did they get their colonoscopy? And I'm sure Dr. Davis and others will expand on that. It provides a wonderful overview of the individual. You lays the groundwork for the care coordination, other things as we move ahead. And it provides accountability for you. You know that that patient is assigned to you, not LifeScan that came in and did it at the local Farm Bureau organization or another organization, but that patient then becomes assigned to you. So it's really critical into the movement of keeping the patients locally and building that rapport with the patient and helping us to better manage our population. So thank you. I know there's a lot more to come, and Jackie, it's back to you.
All right, thanks. Well, I'm actually going to switch over to Dr. Davis. Dr. Greg Davis is our Chief Medical Officer, and he's going to give us an overview of the provider perspective.
Good morning, or maybe afternoon by now. I got to get the technology to work for me. All right, well, I'm going to talk a little bit about, from the clinician's perspective, how a Medicare well visit goes. And I think the first thing is, if you don't have a Medicare well visit program already established, talking a little bit about how you rapidly implement this kind of a program. And it really needs to be a multi-pronged approach. You got to get a lot of different people from the team involved, looking at how things flow through your office, and we'll talk a little bit about that. Certainly the usage of tools which we have provided or are available to you on our website. And if we talk a little bit about just the workflow, how a wellness visit occurs. If we start at the top, I use and recommend, and we have available a mailer to send out. And in fact, in my own practice, I just sent out another 150 of these the last couple of weeks as a second phase process of trying to get people to come in. And it explains what a Medicare well visit is and what it isn't. And it invites them to call for an appointment. It goes through that, this is not a head-to-toe physical examination. It's going to be provided primarily by people other than the direct provider. The mid-level may not be completely involved through the whole process. The physician may not be involved through the whole process, but other people, other licensed people in your office, nurses would be an example, may very well do the majority of this with just a little bit of involvement of the provider. It moves on then to, the next step is getting an appointment scheduled and moving forward then to setting expectations. This is really an important component. They need to understand when the patient comes in, the patient needs to know they're not going to have a pelvic examination and their heart listened to, et cetera. This is really all about identifying health risk factors, not about a general head-to-toe physical. And we need to make sure that we set the expectation with the patient to that so that they're not disappointed. Well, then before the appointment, the scheduling staff, I would encourage you, we're into a point where some of these have been done more than a year ago, and since you have to have more than 365 days since the last Medicare well visit you need to check and see when that last one was done. Otherwise, you don't get paid for this service. I encourage setting a 15 to 30 minutes time frame, asking patients to get there early. We do have a Medicare well visit questionnaire that's available, and I would encourage you to use it. A lot of these are questions that many of your patients can actually fill out in a questionnaire format and save a lot of time in your office personnel. And then we move to the visit itself. Usually it takes about 30 minutes in my office, and my nurse does the majority of these. The licensed clinical staff sits down with the patient, goes through the bulk of the questionnaire, creates a list of questions, recommendations, etc. I'm as the provider, I'm go ahead and seeing other patients in that process, doing usual E&M types of acute and chronic care management. And then at kind of the end of the visit, I step in, and you will need to step in to take a look at a very small segment of that process. Now, you can pick what you want to talk about. You know, you could do the fall assessment or the ADLs or the IADLs, or you may just talk about advanced directives. It needs to be very little direct provider contact, but just kind of I'm going to look this over and I'll get back to you with a list of things that I think would be in your benefit to do. And to that, following the wellness visit, you take all the information you've got, you set up a plan of future care for the next year or two. And I recommend, and what I typically do is write a letter to the patient. I use a word processor where it makes it very simple, very quick, and it's personalized. It also gives that patient that list of things that are going to happen in improving their care over the course of the next 12 to 24 months. You can include in that any kind of handouts that you might like to have from a patient education. You can also include in it such things as a prescription for maybe a mammogram. Or maybe you're recommending that they see a gastroenterologist. You can give the contact information to that type of preventive care type of process. Many times I'll say they need to see an optometrist, for an example, or I may say that they need certain types of immunizations that we don't give in the office, and I'll give them a prescription and tell them where they can go to get that. All included in that letter. And then last but not least, tell them that you'd recommend that they come back in a year and a day to have the next one done, to kind of review the process. So at the time, if we look at a time analysis, it's about 10 minutes for the scheduling staff, 30 minutes or so for the licensed clinical staff that actually administers the process, and then 10 minutes or so for the provider, which would be the quick in and out of the room, kind of summarizing things, and then putting together that document at the end of the visit, summarizing the recommendations. So it's getting pretty close to about an hour's worth of time of your whole office. Well, why bother? Well, we have thousands of Medicare patients that in our ACO that still are due to have well visits. Also, this is a revenue opportunity that is currently not being captured. It's one of our major sources of potential. There's an average visit is going to be in the $140 to $150 range, and since this is going to be provided by a non-practitioner, it's very efficient in the usage of the time in your office. It's also effective, time-efficient preventive medicine. If you're like I am, in the course of taking care of patients where they have 3 or 4 different complaints, it's pretty hard to look to see if they've had a colonoscopy, a mammogram, a pap smear, their last lipids, fasting blood sugar, etc., their immunizations. This is a way that all of that can get captured once a year. And lastly, it is a way to see that missed patient. There's pretty good evidence in the research literature that suggests that for every 10 patients in your practice that are actually you're the doctor for, only 3 of them walk into your office in a year. So there's 7 of those floating around out there that you have a way to now touch through that letter where you're inviting them into a Medicare well visit. I think it's a great opportunity to bring in those patients that you otherwise, they kind of get lost in the flow of an office, because if people don't walk in your door, you don't remember them. Then there's also the revenue opportunity. Looking at some of the revenue opportunities within our providers, I've identified some patients or some providers that have $10,000 to $50,000 worth of additional revenue that could be generated just through Medicare well visits on an annual basis. Significant chunk of change. It does also update our medical records, and as Pat said earlier, in this process, it allows us to really do our coding, allows us to define the severity of the illness of our population, sets better benchmarks for the ACO, and since CMS makes a decision regarding whether or not we will be able to achieve Medicare well shared savings based upon the severity of our population, we'd like to really characterize our population as accurately as possible in the level of severity of their illness, because it makes a big difference on our benchmark that we have to beat in order to get Medicare well shared savings. And with that, I'll back to Jack.
So does anyone want to have a question session at the end, but I didn't know if there were any providers or anyone on the call that wanted to jump with any questions for Dr. Davis? Please, Jack. That would be a wonderful thing. Thank you. All right, we're going to move on. Again, there are someone talking in the back of your phone so that the rest of us will not have to hear your background noise. Okay, well, moving on, this is Jackie again, and I'm going to talk about components of the first thing, I want to thank Brooks at Mason District Hospital for providing us with this really cool algorithm for the registration folks to help them decide how to schedule and which visit to schedule. So basically, it just follows through a flow diagram. If they're in their first year of eligibility for Medicare and have not received their initial visit, they're welcome to Medicare. You put them into the yes column and you schedule it. Or put them into the no column and schedule it. If they've already had one, then you can be proactive and schedule their annual initial well visit 1 year plus 1 day from their initial welcome to Medicare visit, and so on. It's a very nice, clean algorithm. This is a 2-page document, and it's got a lot of other information, and it's going to be available on our website, and I will give you the link to that later. But just a very nice overview that simplifies the process, because we've had feedback that sometimes it's difficult to figure out which visit to give them and at what time. Documentation is very important. Coming from the coding side of things, you could tell us that they're there for a Medicare well visit, but if you haven't hit the required elements that have to be on that documented visit, we can't, as coders, assign those G codes and bill that. So it's a team effort. The coders need to be sure that they're watching the verbiage and watching the elements, the key elements that are required, and then the providers need to be giving us all of those information. So this is just an example of the components. I know it's kind of small print, but I'm trying to bring your eye to the required elements portion where it says, at a minimum, collect the following. These have to be on your documentation. So if you're making a template in your EMR, be sure you've got required markers for all of those elements. If you miss something, then it's not billable. If you bill it and you don't have the required elements and you get audited, you're going to have to pay the money back. So I just can't stress that enough. There will be links to sample documentation that you can use, and also some Medicare tools that give you this in a prettier format for the Welcome to Medicare and the initial and subsequent annual well visits. One of the questions that is asked frequently is how do you know if they had it before? How do you know if they've been in the life scan truck 6 months ago? and had this done. Well, there's different ways you can do it. If it's been long enough that the claim has been processed and is on eClinicalWorks, you can look there. You can look inside your own internal billing system and check for those G-codes to see when they had it last, if they had it billed at your facility. Or there is something else called the Health Eligibility Transaction System. It used to be called the Common Working File, and your billing department has access to that because you are Medicare billers. You can dig inside those claims history for those folks, and they will be able to ping and see if they've had that G-code within 12 months or not. They use that also to check eligibility. So your billing department are the folks that have the rights to this, this website, and those are the people that you'd want to check with if you can't find any other methodology of knowing when the patient last had their visit or if they last had their visit. So eClinicalWorks dashboard is what I was talking about earlier. I've got some instructions. I've got the website address and where to go into the report center and how to pick the dashboard for Medicare well visits. And when you do such a thing, you'll land on the current opportunities tab. This is just a quick snapshot. Most of you know how to do this, but if you needed to go back through, I just kind of wanted to bring it to your attention. And I can give you much more detailed training offline at a different time. So the Medicare Well Visit Dashboard has 9 different tabs, but the circles tell a lot. So when you go in and you set your filters, I want you to understand what you're looking at with the 3 circles. The first circle says this is how many patients overall that are due to have a Medicare well visit, whether they've had one or not. This is everybody. The middle circle is those folks that have ever had one. That's the ones that are due out of all of them. Out of all of your patients, these are the folks that have ever been G-code billed. And the last one is these folks have never ever even had one. So out of this whole bucket, these people have never even had a wellness visit. So as Doctor was mentioning, there's a lot of potential for revenue and for capturing patients out there. This is old numbers, so please don't act on any of these numbers. Okay, again, kind of small print, but it kind of tells you how to go and select your filter, and you can select your location so that you're only looking at your hospital. And then it tells you to go to the Patients Due Now tab, and when that big file comes up, if you right-click anywhere on the table, you can export the file into a much more readable, usable, sortable Excel spreadsheet. So this is just some quick snippets of how to work that. I'm going to switch over to billing and coding. We're first going to start out by talking about the initial provider, initial physical exam, even though it's not a physical exam. I don't know why they call it that. It's the Welcome to Medicare visit. So the G code associated with that is the G0402. These other codes are codes that you would bill if your provider decides that an EKG on this first time is warranted. Be sure when you're sending these EKGs out, you're using the G codes along with it, or they'll fail because they're going to pass. They're going to be looking for the G0402 to be billed with them, and so that's just something that you need to kind of be aware of within your facility when you're billing. Generally, when they're doing it during a CPOE electronic order, they're not necessarily grabbing the Medicare code, they're grabbing the regular code, and we see a lot of claims get messed up with that. So just bringing that to your attention. Another thing to bring to your attention, when you're doing a Welcome to Medicare visit, you can provide a separate E&M service that same day, only when it's a Welcome to Medicare, not the annuals, but that is allowable and will be separately reimbursed for rural health clinics or non-rural health clinics. Diagnosis codes. This is the chance for your provider to list all chronic conditions associated with that patient and get them on the claim. This may be your only chance in a 12-month calendar claims data to get that real true severity of that patient on a claim. Once that 12 months is closed, your costs associated with that patient are done, and you're going to get X amount of money to take care of them. And if you didn't properly tell CMS how much is wrong with that patient, you just won't get enough money to take care of them, hence you won't share savings. If they have no chronic conditions, you can do the preventive exam with or without abnormal findings, and you can add that as another code on the claim as well. The annual wellness visit, there's the first one that they're eligible for once in their lifetime. It does not have to be the second year they're eligible for Medicare. They could have been on Medicare for 8 years and never had a welcome to Medicare, but now you've got them coming in. You bill that initial annual wellness visit one time ever, one-time benefit. After that, you bill the subsequent from here on out, 366 days from the last one. So in a non-rural health clinic, you can also bill a separately identifiable E&M, but in a rural health clinic, you are only going to get your all-inclusive rate. So we recommend if someone has a problem and an illness and they come in for their well visit, probably want to reschedule that well visit and address their chronic problem or their acute problem. Just because it's a benefit they would be losing, they're not paying any deductible or copay for their well visit, and you're going to lose that if you mix that in with the sick visit. Again, can't stress enough, we need those providers to list all those chronic conditions on that claim, and then the no chronic conditions, you can use the Z codes. They don't have to address them in this visit, which is such a great timing. They just have to get them on the documentation so the coder can get them on the claim. Okay, so we're pretty excited that we've got two wonderful locations that are willing to talk about their design and implementation and their perspective, how they've come along with their Medicare well visits in their practice. Our first presenter is Katie Musil, and she is the clinic manager at Midwest Health Clinic in Galena, Illinois. And I am going to turn the microphone over to Katie, and I will go ahead and advance your slides whenever you need me to.
Well, thank you. I appreciate the warm welcome. Hello, everybody. I am Katie Meisel. I am with Midwest Health Clinic and Midwest Medical Center up in Galena, Illinois. We are located in Galena. We're about 12 miles from Iowa and 6 miles from Wisconsin. So that kind of gives you an idea generally where we are located. Galena is a town of about 3,500, and our county is Joe Daviess County. We have about 22,000 people total in our county. I have been with Midwest Health Clinic for about 1.5 years now as the clinic manager. It's a very small facility. I believe this past year our hospital and our clinic total have reached out and assisted taking care of about 10,000 patients at this point. So we are in a very small location. We have 2 clinics, an Elizabeth Health Clinic in a neighboring town about 12 miles away, and then we have our family practice and internal medicine clinic in Galena located within our hospital. So I have 7 providers total, 2 of which are nurse practitioners. 1 is in our internal medicine and 1 is in our family practice location, and I have 4 family practice physicians, and I have 1 internal medicine physician. So that gives you a general idea as to where we are and who we're working with. Go ahead to the next slide, please. So here's just a brief overview. Like I said, I've been with the clinic for about 1.5 years now. I was really educated back in July of 2016 on the annual wellness visits. Actually, my CEO sat down and said, these annual wellness visits might be something very good for us to start. We should look into this. And that was put on my plate, which was awesome. Very, very quickly, we learned that we really needed to have a care team put together. So in August of 2016, myself, another nurse who's part-time, and 2 nurse practitioners, one who's actually a student who's been donating a lot of time to our facility, and 1 of our nurse practitioners who worked at our facility. That's the start of our care team. We don't have a lot of extra staff around here, so I kind of threw myself into that nursing role to begin with. So we learned about the annual wellness visits. We threw the care team together right away. And September of 2016, we really started the educational process to all of our staff and our providers. that was something that it took a lot of time and effort for us, but we put workflow samples together, we put PowerPoint presentations together. I think a lot of that stuff I have shared with Trudy and with ICANN, so I believe ICANN does have some of our information up on their website as well as other resources for anybody, because we understand this is a process to go through, so whatever we can share with anybody else is good. So we did provide a lot of different education to staff and the providers. And then come October 1st of 2016, we made a clinic goal, just a little clinic goal to complete 50 annual wellness visits. We had never completed one annual wellness visit up until that point. We didn't even have the templates built to complete them. So we thought 50 annual wellness visits was doable. We could do it by the end of our fiscal year, which is September 30th, 2017. Our administration was great through this whole process because they did not give us any specific requests. They didn't say we had to have a certain amount done. They basically understood that this would be a process, it was going to be a change, so let's start in at it slowly and see how we can start these and how we can educate people on these. Next slide, please. So we learned about the annual wellness visits, like I said, in July, August. We threw our care team together. We made some small steps, basically, at that point. So the care team, it was the 2 nurse practitioners and myself and another nurse. We had a lot of conversations with our CEO, our CFO, our IT nurse, and our third-party biller. We had a lot of phone calls just to try to figure out what processes were, and asked all the questions that we needed to. And actually, our billing department was a phenomenal department to go to ask any questions. We still go to them frequently if we have a question arise. And the billing and coding has been a wonderful hand to help walk us through this as well. So then what we did from there is we had a nursing workflow change take place in November of 2016, where we have Cerner as our EMR, and they had created some Medicare intake forms for us. These Medicare intake forms were something new. It was very similar to our other adult intake forms that we did. It just had a little more detail. So November 2016, I made it a rule that anybody 65 and older, we had to complete a Medicare intake form on. It didn't matter if they didn't have Medicare or if they did have Medicare, but this is what we had to do. So the nursing staff completed that for about a month. Then in December of 2016, I made another workflow change, basically saying that now we have to throw in the annual wellness visit requirements on the intake. So all of the nursing staff had one-on-one meetings with me where we could talk about it. Each nursing staff member got a little cheat sheet that they actually taped to the corner of their computers so they could utilize that, so they knew what had to be completed for the annual wellness visit requirements on this. 2 of my nursing staff members do these annual wellness visits the most. Robin is one of them, and she is one of our CMAs. She has said that the first 4 or 5 that she did, yes, were extremely time-consuming, and it was a change. She has done many, many more now, and basically she says it's just like the DOT. Once you get it down, you get your set way of doing it, and it works very well, and it goes a lot faster. So a lot of education just came along with this. Then we created templates for our providers. Cerner did not have any templates created for annual wellness visits or the IPPE visits. So at that point, our nurse practitioner on our care team, Peg, put together templates for all of the providers, and she went through and educated each one of our providers individually on these templates, which was extremely beneficial. And that was actually towards the end of October that was completed. And what we have done since September is we have had monthly staff meetings where with the provider meetings, we discuss the annual wellness visits and how they're going, and the staff meetings, we discuss it as well. And that has just been crucial because we get a lot of questions out there at that time. Next page. So this shows our epic failure, and I will say it that way. So October, November, December, this shows we completed bare minimals here. October, like I said, the templates weren't up until the end of October. So really, in about a 3-day period, we completed 2 annual wellness visits. So that was nice. November, we only completed 2. December, we only completed 4. With reviewing this, only one of our providers, our nurse practitioner who was on our care team, had completed an annual wellness visit. So at this point, it was, okay, what are we doing wrong? Do we need more education? What needs to take place? Because something's not working right. So I went back to our provider meeting, and we sat down with the providers and said, what is not working? How can we fix this? At that time, the physicians said that they actually did not want to be doing the annual wellness visits. They wanted the nurse practitioners to do them. I have one physician who still likes to do them, and she does do them. But otherwise, the rest of my physicians said, no, let's have the nurse practitioners do it. That was the care team's initial idea. That's what we wanted to do, but in the very beginning process, the providers all said no. They wanted to do their own patients. So I gave them a 3-month time period to really test those waters and see if they would complete them, and they didn't. So at this point, we totally reevaluated the program and figured out a new way of going about things. Next slide, please. So the providers, the physicians said they did not want to be completing the annual wellness visits, and they wanted them to be completed by the nurse practitioners. They also wanted these visits to be clean and clear, nothing more, nothing less. We had really tested the waters and asked a lot of questions to poor ICANN in regards to what we could and what we couldn't do. We had a new provider join our facility in November of 2016, and he has been nothing but an asset. He has been tremendous, and we don't know what we were doing without him. But when he came, he had brought up some things that his old practice had been doing with annual wellness visits. So it really made our physicians question what we could, what we couldn't do. So we tried to muddy the waters a bit, but with doing that, we learned that, no, it needs to be clean and clear. If you're doing an annual wellness visit, just, it's only an annual wellness visit. Even with the IPPE visits, our providers say just an IPPE visit, that's it. So that was definitely a change, but it took a lot of conversations to get us to where we are at now. Next slide, please. So we are carrying on with the annual wellness visits with our new plan of action. January, we completed 7 annual wellness visits. This was between 3 providers. And then February, this was only 1 provider, completed 4 annual wellness visits. Our goal is for 50 of them to be completed by September 30th, 2017. Actually, one of our care team members, Peg, our nurse practitioner who's been doing these, was off for about a month, so we didn't have her here to complete these. She has since returned, and with her return in 1 week, she's already completed 2 or 3 of the annual wellness visits. So we're back on track to where we want to be. And through June 12th, we actually have 25 or 27 more annual wellness visits scheduled, which is really, really a good thing for us. We've been taking this slow and steady and asking a lot of questions along the way. So next page, please. So my whole point here from my perspective is the struggle is real. We've been through the struggle. We still are going through the struggle because it's a continuous process. I mean, it's not going to solve itself very quickly, and we are constantly having questions on it as well. But that's good because we're constantly learning as well. So we've learned it takes time. Nothing happens fast with this. As you heard me say, we had a game plan set in the beginning. The providers decided they wanted to see their own patients, and 3 months in, they said, no, this isn't working. Let's switch it back. So even in the middle of our annual wellness visit year of trying to get 50 completed, we had to change and make a new plan. Also, I found I can't force it. I have to allow it to go at its own pace. I am continuously educating all of my staff, all of the providers. Basically, I want to see their eyes roll and glare at me when I start talking about annual wellness visits because I want them to hear about it so often. But it's something that they are continuously learning about. It's constant education. Each month we go over the information. And even if I just have annual wellness visits on my agenda and nothing more, there's a conversation that spikes, and there's lots of questions. And then it's just a constant review of the procedure and how you're doing things. It's never ending, and it's constantly making things better. So, and like I said, through June 12th, we now have 25 more of these scheduled, and hopefully we'll be able to reach our goal, and hopefully we'll be able to continue on this and get even more patients next year. That's all I have for you today.
Thank you so much. That was wonderful. Does anyone want to jump in with any questions directly to Katie at this point?
Yeah.
Okay, we'll go ahead and everybody. We're going to move on to our second presenter. Jennifer Wellbaum from Payne and Community Hospital is going to talk about her perspective in clinical practice with the Medicare well visit. So I am now turning the microphone over to you, Jen.
Okay, thanks. You can go ahead and advance to the next slide. This is our approach. It's probably a little bit different. I think everybody's going to have their own ideas and workarounds for different things, and so we just wanted to give you an idea of how we worked through the process. We go ahead and go to the next slide. A little bit about us. We have 2 clinics. We went ahead and implemented with one to start with because they are 2 separate family practices. So the clinic that I'm going to be talking about has 3 primary care physicians and 3 nurse practitioners. We also have 3 locations that those 6 providers go to. We have one in Pana, which is a rural health clinic, and then Assumption and Nokomis are our other 2 clinics. And actually, they're being surveyed today for rural health, so it'll be interesting to see how that changes our workflows going forward. You can go ahead and go to the next slide. So right now, I'll start with round 1 is what we'll call it. In our community medical clinic, we were actually really slow to get started. We tried cold calls that were assigned to our receptionists, and they really didn't get a lot of training or really have any knowledge of what they were asking the patients to come in for. They kind of just got thrown into it and given a list of patients. Surprisingly enough, this approach wasn't very successful at all, and we had almost nobody come in to get these done. So no training, no explanation, pretty much equals no results. So we learned that one pretty quickly. So next slide. In round 2, we switched to a system where we had 1 nurse calling and scheduling, and her job was basically to sell the Medicare well visits. We then had a different nurse who was assigned to do all of the actual prep work for the visit and hand it off to the doctor and document in the same way on all of them. It was standardized, it was centralized, and once we got them going, it worked pretty well. We had better results. The problems happened when a patient wasn't available on the days that she was available, because she was only available 2 days a week, or for some emergency, which happens often in our clinic when we're tightly staffed, she would get pulled to another area for the day that she was supposed to be scheduling Medicare well visits, and then we would lose a week. We also had another big issue when she decided to go back to school and cut her hours. She was the only one who knew how to do the visits, and they kind of fell off the radar for a while. And then it eventually got to the point where she was working in another specialty clinic, and then she wasn't available to us at all. So for that first 10-month period, it looks like, from November of 2015 through September of 16, we actually had a total of 102 Medicare well visits. So that was kind of our round 2. So next slide. When Lori got pulled from us and we realized we didn't have a nurse to do the well visits anymore, we started looking at things a little bit differently. Again, like Katie said, you're constantly looking at what you're doing and reevaluating to see where changes need to be made. So in this last round, third time's a charm for now, we stepped back and looked at the situation, and we are working toward PCMH certification. So because of that, our patient load was already divided into 3 teams. On each team, we have a physician, a nurse practitioner, 3 nurses, and 2 receptionists. So those patients are already familiar with the nurses and receptionists on their team because we try to divert those calls when they call in to a team member, and they are consistently seeing those same people when they come in for visits. So we made the decision to try to approach our Medicare well visits in that same way. We decided that each team would be responsible for scheduling and completing their Medicare well visits on days that worked for the staff on that team. Communication between scheduling and nursing was really the key. They had to figure out days and times that they could do those, and then let everybody know the days that they were available so that when those calls came back in from the patients trying to schedule, we knew when to put them on the schedule. We have an Excel spreadsheet that's available to all the team members for their patient block with the patients who are eligible for Medicare well visits, and that's updated at the beginning of the month with new patients. We don't start with a clean list every month because the nurses like to note in the list when they've spoken to a patient who might have deferred or refused, and we don't want to get to the point where we're annoying them with so many invitations. Nursing does do some cold calling when needed, but the majority of our well visits are scheduled after the patients have been seen in the office. We have 1 billing specialist who reviews the appointments each morning, and then she reviews the Medicare patients for eligibility. Once she establishes that the patients are eligible for a well visit, she sends a message to the team nurse mailbox, and then they discuss it in morning huddles where they meet with their physician or their provider in the morning to discuss the schedule for that day. So say Mr. Jones is going to be here for an acute visit and he's eligible for a well visit, then they can tip off the physician to discuss it with him. And then he can ask questions and we can get him scheduled before he leaves the office. As we all know, and this has been well proven in our practice, the patient will agree to more if the provider discusses it with them. We've had patients who have declined multiple times, suddenly agree to schedule an appointment for a Medicare well visit just because the provider brings it up and says it's a good idea. Next slide, please. The appointments are scheduled on the team nurse schedule. We have a red schedule, a blue schedule, and a green schedule for the nurses. And when that patient arrives, the team nurse takes the patient back and starts the visit. We had the original nurse who was doing the well visits train the rest of the staff on her routine. We have a standardized template in the electronic record for the reason for visit, for the screening codes, the ordering codes. So all of this is in one place for nurses to walk through, for the providers to walk through. We've tried to make it as accessible and easy as possible. We have a policy and standing orders in place so that the nurses can add items into the visit as needed, and then the physician signs off on those. The nursing staff has also devised a cheat sheet to put on their computers and to check off as they go through the visits, similar to what Katie was talking about with on their computers. And then we've kind of set it up. It's almost like when you go to the dentist and you're there for a cleaning and they let the dentist know that you're ready for your checkup, and then he comes in at the appropriate time. It's kind of how we have it set up with our well visits. The nurse goes in and does her part and gets everything done, and the physician continues to see patients in an appointment queue, and then when he's available, he'll pop in and see the Medicare well visits and go over their recommendations and the findings that the nurses have done throughout the visit. We also take nurse practitioner appointment openings. When they have an open schedule, we will put them on there also so that they can spend a little bit more time with them if needed, and we can also schedule the patients for follow-up. Next slide, please. Let's see, starting in the fourth quarter of 2016, our staff has been given quarterly goals by our lead physician and then the CEO of the hospital, and they met and exceeded the goal for the last quarter. Their goal was 100, and they actually got to 105. So there was a really big push at the end of last year. And then the administration set our goal for 2017 for 400 by the end of the year, so that equals out to 100 each quarter. And we've been a little slow getting started for this year. We're actually behind pace, but I think that's because there was such a big push in December. So we're hoping to get them motivated using a little friendly competition, because that's always a good thing between teams, so we can kind of motivate them that way. We're not above using food and pizza parties as prizes for those competitions. So next slide, please. So lessons learned. Like I said in the beginning, we were actually pretty slow to get started. Nobody understood what we were trying to do, and we really didn't have any physician backing. So I'd say the most important part before ever getting started is to make sure that you start communicating from the very beginning. The best thing that we did was find a physician champion who understands the need and the why of what you're trying to accomplish, and then meet with the rest of the staff and present that idea to all of them. Listen to ideas from the people who are actually doing the visits and come up with a plan that works for your practice. Try again and again and again if something isn't working the way that you thought it would. We're in a constant state of change in this field lately, but good patient care is always going to be the key, and these visits can help your patients and your practice. Then next slide, please. One of my favorite quotes from Mother Teresa that is always appropriate, and especially in healthcare during this time. So that's the end.
Wonderful, Jennifer. That was amazing. You both did such a good job. Does anybody in the group have questions for Jennifer? Hello.
Sorry, I'm trying to stop it.
Bear with us. Awesome. All right. Any questions that you have, I'll have contact information at the end, and also you can reach out to your regional care manager or any of these wonderful ladies that were giving of their time today. A few pages at the end of the slide presentation, some resources. We have an Arico website with provider resources. If you haven't got a login, Lindsay Toth is your girl. There's the American Academy of Family Physicians sample Medicare preventive physical form. This is a link to the actual website for them. There is also the same information on our Arico as well as our ICANN website. You log into the website under member login, go to the ACO button, and start scrolling down under care coordination, and there's a Medicare well visit packet with all of the things that we've talked about today, Dr. Davis's letter, etc. Also, the links I promised to the ABCs of both the Welcome to Medicare and the annual wellness visits with lots of good information. And then a nice little information about health risk assessments at the CDC's website. It actually has a sample one you can download and use. And then again, our contact information and kind of what we do overall at the Arico ACO on this last slide. We will go ahead and send the slide packet out after this presentation to the Arico and the care coordination listserv. And I want to open it up one more time. I'm kind of scared to. If there's any other questions, otherwise, anybody have a question for the and it will be put out shortly afterward once we get the recording completed along with the slides. So we thank you for your attention. We thank Katie and Jennifer again for their input, as well as Dr. Davis. And we hope you all have a wonderful week, and let's go get those Medicare well visits done.
Go, girls. Bye. Are we done?